Hi, everybody. I'm sorry I wasn't able to be here yesterday, but I'm so glad to be here, not only to speak this morning, but to be with you and participate throughout the day. And if I can stay awake long enough, even maybe a little bit of dancing. As Barry said, I'm here representing the National Women's Health Network. And the network is an independent, non-governmental organization, nonprofit organization. And as such, we don't develop data at the lab bench or in the research trial. We develop our analyses of health issues through a collaborative process. So I'm going to acknowledge the women I've worked with at the National Women's Health Network over the years in which the network, have developed the things and worked on the issues I'm going to talk to you about today. And Barry did ask me to try to kind of sort of somehow get in with the theme of the day. I'm not going to talk about the analytical approaches, but I will touch on those criteria for overdiagnosis and the existence of a silent reservoir of disease. Well, I think Barry knew when he invited me and the other people on the steering committee who were whispering in his ear that I was going to bring up another criterion for overdiagnosis, which is medicalization, and specifically the over-medicalization of the normal experiences of women's lives. So, are women vulnerable to overdiagnosis? Yes, I believe they are more vulnerable than men, although the importance of overdiagnosis in the health of men and children is of interest to us, is real, we accept that. And I would say because there have been women's health groups, not just the network, many great writers and thinkers, as well as our advocacy organization, that we have a little bit of a head start in some ways, at least in the States, about how some strategies that can eventually sort of ramp back overdiagnosis and improve the harms that are created by overdiagnosing and overtreating. So to make that point, I'm going to talk about consumer advocacy, women's health, and specifically female sexual dysfunction, hypoactive desire disorder, and menopause hormone therapy. So starting off with desire. Well, what's too much desire? What's too little desire? It depends not on who you ask necessarily, but on where you are when you ask the question and when. So if you were in Victorian England 150 years ago and asked that question, well, too much desire was anything that was more than a woman's husband was interested in, or more than anything at all if a woman wasn't married. So that was a diagnosis. Those women were diagnosed with a medical condition of too much desire, various names given to it, various treatments used for it, some of them horrific. But now we have the diagnosis of too little desire. Now, I'm the first to admit that human history is full of examples of men and women looking for ways to make sex better. This idea of either wanting more desire or wanting the sexual experience to be better is not created from whole cloth by the kinds of cultural attitudes that created what seems so obviously wrong to us now. But it has been the articulation of female sexual dysfunction as a disease, or a set of diseases, and of hypoactive sexual desire disorder as a subset of that. That was explicitly developed, promoted, and moved to acceptance. And many thanks to Ray Moynihan and Barbara Mincies for writing this great book. There are many other really good articles, including several by Leonore Tiefer, who's here in the audience today and is speaking later this afternoon. So I'm going to talk today about the first drug approved by the US Food and Drug Administration for female sexual desire disorder. It's called Flibanserin. It was approved less than a month ago. It's a very upsetting story. It shouldn't have been approved. It should not have been approved, but it was. And the fact that it has been approved is going to lead to a tsunami of overdiagnosis, because of the medicalization, not necessarily because there's a reservoir of silently suffering women, but because of the medicalization and the promotion of a normal event or a normal state as a disease. That overdiagnosis and overprescribing is going to lead to women getting hurt. So let me tell you a little bit about the drug. Unlike other previously proposed but not approved treatments for female sexual desire disorder, flibanserin doesn't affect blood flow, it doesn't affect testosterone levels. It was originally researched as an antidepressant. It affects the levels of dopamine and other chemicals in the brain, and it's designed to be taken daily, regardless of whether a woman thinks she might want sex later that day or not. It's a daily use drug. So here is a big part of the reason why we think this drug shouldn't have been approved. It barely works, if at all. And I'm showing you a bar graph there that looks like there's a difference. So that looks like it works, right? But that is the result of a trial that was done after the drug failed its first primary efficacy trials. That failed the endpoints. It failed to find difference in the primary endpoints. The FDA said no. The company who was sponsoring the drug at the time stopped research on it, but another company picked it up and convinced the FDA to let it change the primary endpoint. So these results are from one of those later studies, and they show that there's a strong placebo effect. 34% of the women responded with more sexually satisfying events, at least minimally, on placebo. But 44% responded on flibanserin. So there is a statistically significant difference. What counts as at least minimally approved or as measured was a little less than 1 event per month. So it's arguable, is this an effective drug or not? But in addition to these effectiveness, not so great, the adverse effects were pretty striking in all of the pivotal trials, both the first time and the second time. These trials found low, but statistically significant, serious, and potentially life-threatening adverse reactions. And that is part of why the FDA said no the second time around. So the most serious adverse reactions to this drug are sudden prolonged unconsciousness and severe hypotension with diastolic readings in the 40s. The FDA asked the company to do some interaction studies to explore these safety signals that were seen in the RCT, and 2 of the drug-drug interaction studies had to be stopped early because everyone experienced adverse events. The drug-alcohol interaction study doesn't tell us much about women because only 2 women were in the study. 23 men, of whom 4 needed a clinical intervention. So those interaction studies didn't relieve the concerns. To us, it looked, and I stood up and said this at the FDA Advisory Committee, this drug shouldn't be approved. At least, it certainly shouldn't be approved without a study of the use of alcohol in women. But the FDA did say yes to it, as I showed you. And not because there were new data, there weren't, but because of an expensive and clever pressure campaign that was orchestrated by the company. Here's a slogan of the campaign that led to the approval of flibanserin and to what I predict will be this coming wave of overdiagnosis and overprescribing of flibanserin. It's a great slogan, isn't it? Women's sexual health equity. I want women's sexual health equity. It's a brilliant slogan, but on the surface, it sort of solidifies the medicalization of women's sexual experience and the overdiagnosis. There's so much to say about even the score, but I'm not going to say it this morning. Instead, I encourage you to go to Leonore's talk later today if you can, or go to the New View website, which is the project that Leonore leads and that the network has been a supporter of. So what's coming? Well, adverse events are going to come. They were found in the randomized controlled trial. There's statistically significant difference. They are rare, or at least uncommon. But the claim about hypoactive sexual desire disorder is that it affects 10% of premenopausal women. That's a lot of women. And there's already talk about using an off-label. Some of the physicians associated with the company have talked about that in public, in print. So could be even more women who are potentially exposed to this drug. And if the number needed to harm is 330 and there are millions of women exposed, that's a lot of harm. Now maybe, what if this number's wrong? What if it's wrong by an order of magnitude? That's still a lot of women who are likely to be harmed. So as a women's health activist, I feel like the movement for the prevention of overdiagnosis needs to take this up this issue and try to turn it around. It won't happen right away, I know that, but I still think if we speak out against the overdiagnosis and the overprescription, that we can mitigate the harm that otherwise is going to happen. And the reason why I'm so convinced that we can speak out, that bringing consumer advocacy and an analysis and evidence together to make a difference, is because we did it once before with menopause hormone therapy. So just to remind you of the hormone replacement therapy story, and to maybe share a little with some of the international participants who didn't experience it in quite the same extremity that we did in the United States. Here in the US, the use of hormone replacement therapy was a triumph of marketing over science. It was only ever approved for hot flashes, for treatment of hot flashes and vaginal dryness, and for osteoporosis, but it was marketed for every condition associated with aging, and just plain aging. And that marketing went both to consumers as well as to clinicians. I'm going to show you in some way that is supposed to just happen. Maybe I keep clicking. Activism's my bag, not technology. So marketing messages stressed over and over and over again that menopause is a deficiency condition and that hormones are replacement. And that definition was powerful. It was repeated for decades in messages directly to women. And even more importantly, it permeated the education and training of clinicians. That's an ad that was directed at physicians in a medical journal, obviously by the close, in the era when medical journals were assumed to be no one but a physician was turning the pages. And these messages, the permeation of this idea that menopause is a deficiency disease, that's a diagnosis, and that replacement treatment hormones are actually replacement, that was so ingrained in the United States culture that it was in the guidelines of the American Heart Association for prevention of heart disease in postmenopausal women. And for a while, it was even included in, it was one of the measurement criterion in the healthcare effectiveness data and information set, HEDIS. When it was so widespread that between 1 in every 5 and 1 in every 4 postmenopausal women used hormones. Some of them were using them for symptoms, sure, but the use of these hormones for women in their 70s was very significant, when clearly there in the 70s, those women were being told they were using it for prevention of heart disease, prevention of Alzheimer's. And we knew that there weren't any randomized controlled trials showing those clinical benefit outcomes. There weren't any randomized controlled trials of showing prevention of heart disease, prevention of Alzheimer's. There were lots of observational studies, and there were RCTs with risk factor outcomes or intermediate endpoints, but the overdiagnosis and the overpromotion persisted even when the evidence wasn't there to back it up. One thing that was particularly upsetting at the time and sort of foreshadowed the success of getting the FDA to change its rules and let the Flibanserin sponsor use a new efficacy endpoint after it failed the first one, is the sponsor of Premarin tried to get FDA to change its rules for approval of drugs to prevent heart disease, where in men they required RCTs for everything, even baby aspirin. They asked the FDA to approve Premarin for prevention of heart disease in women who'd had a hysterectomy with no RCTs, just those observational studies. So this was a big problem. So many women on estrogen and combined hormones thinking it's replacement, thinking it's preventing a disease. And consumers spoke out. The network was one of the leading groups, Public Citizens Health Research Group, some other groups. We spoke out. We never really changed the proponents' minds, I have to say. We never did. But we found a way to change policy. And we went to policymakers, FDA, health policy, Congress, and the NIH, and said, where's the RCT? Where's the evidence? Women deserve this. And finally, we got that. We got the Women's Health Initiative. And that study showed that women who were taking hormones strictly for prevention ended up with more adverse effects than benefit, that it didn't do any good to help if you age healthfully, to get on hormones. And that information was communicated directly to women by the NIH through press conference. Women heard this new evidence. They voted with their feet. Many women who only had a prevention reason for using it got the message and stopped. And within a year, breast cancer rates fell in registries around the world. And that's because we were able to change the overdiagnosis, to really push back on the idea of menopause as a deficiency disease and the conception of menopause hormone therapy as replacement. But you know, even though I take great pride in that, and that was a consumer-led victory, we couldn't have done it without researchers. Obviously, researchers did those trials. Those were big, long, hard trials to do. But researchers also stuck with us when we were just out there saying, you know, there's another perspective on this. This is a book we wrote in the late 1990s, and many epidemiologists and researchers reviewed our work, told us we were articulating the evidence correctly, and some were able to let us use their names, and that's important. Scientists and researchers backing up consumer advocates is important. So here we are now. We've got Flibanserin expected to be approved and used and marketed. It is approved, and it's expected to be marketed as soon as October 18th. We need to speak out against this. We need to articulate the kind of critique of the overdiagnosis of female sexual problems that was successful in articulating a critique of treating menopause as a deficiency disorder. And consumer advocacy groups can help. We are, you know, this is what we want to do. We want to make, as Barry said, speak up for the healthcare that women need and not the healthcare that they don't need. But when I encourage you, as you know, the treasured few researchers and scientists who are committed to investigating overdiagnosis and overprescribing and overtreatment and these harms, I encourage you to seek out consumer advocacy groups to ally with. I do have to say that not all consumer health organizations are created equally, and more importantly, not all consumer health organizations are funded equally. That this is an incomplete list, but it's not an incomplete list by an order of magnitude. The number of organizations in the United States that are able to sustain themselves without taking drug company money is small. And with some exceptions, we are the organizations who are most who are best at using evidence and speaking to the evidence. So I want to reach out to you and to say, stand with consumer organizations, we need you. And also, I want to reach out to you and say, we can help you. We can speak in venues and to audiences that you don't. Also, we can be opinionated. In fact, it's our job to be opinionated. So, you all create the evidence. We create a disruption of the narrative, and together we can make policy change. Let's get started. Thank you.